Welcome
Pausing
back to the deep
important
dive.
developments
So,
in
if you're a medical
healthcare
professional and you're
technology.
looking to
Our team
certify
is
commercial
dedicated to
drivers, you
advancing medical
probably already know
education.
this. The path to becoming a certified medical examiner, it's less about your day-to-day clinical practice and, well, it's entirely about mastering a rule book.
A very specific rule book.
Exactly. One designed for the entire national road system. Our mission today is to really unpack that rule book, the standards from the FMCSA, and more specifically, the NRCME exam that, kind of guards the JATE.
It's a deep dive into regulation, not just medicine. And you have to understand that when you step into this role, you're no longer just the treating clinician who's focused on the patient's wellness.
You become a regulatory gatekeeper.
That's the perfect way to put it. The whole challenge of the NRCME exam is to understand and apply these really specific, quantified public safety rules. We're talking down to LVEF percentages and mandatory waiting periods, even if they seem to clash with how well a specific driver has recovered.
Right. This is exactly where your clinical nuance meets a very black and white occupational safety regulation. And to pass, you just have to know those lines cold. So let's start with the basics, the administrative ground floor. Getting certified. Who is actually eligible to sit for this exam?
Well, the FMCSA has opened the pool pretty wide. It covers most licensed practitioners who would, typically be performing physicals anyway.
So we're talking MDs, DOs.
MDs, DOs, chiropractors, DCs, and then all the various advanced practice nurses. So your APNs, APRNs, NPs, and of course, physician assistants, PAs.
And the path to get there is very structured. First, you have to complete an accredited training program. That gets you a certificate of completion. But then the real administrative hurdle starts. Right?
Oh, yeah. Applying to the DOT-FMCSA, getting verified, and then receiving that all-important 10-digit national registry number.
And what does that number do?
That number is basically proof that the FMCSA recognizes your training and says, yes, you are eligible. Once you have it, then you can go schedule the test.
Okay, so the test itself, it's about $80, and it's administered in person by appointment.
Yep, through vendors like Prometric or PSI. They have locations all over the country, and they often offer Saturday morning slots, which is really helpful for working professionals.
The security measures, though, they sound intense. We're hearing this is a strictly closed book, computerized exam, and they screen you pretty rigorously before you go in.
They do, and that level of intensity really tells you how high the stakes are for the certification. You have to remove everything from your pockets, absolutely no items, no phone, no notes, no pens. Nothing goes into that testing area.
They wand you.
They routinely wand candidates. It's an environment designed to make sure they're testing your pure knowledge of the regulations, not your ability to look something up.
Okay, so let's get into the mechanics of the test. You've got 2 hours, 120 multiple choice questions. That's what, 1 minute per question?
Exactly, 1 minute per question, which means time management is absolutely critical. You have to be decisive.
The computer format must help a bit, right? You can eliminate options, flag questions.
It does. You can flag things to come back to. But here's the big quirk of this test. Only 100 of those 120 questions are actually graded.
Wait, really?
Yeah. The other 20 are pilot questions that the FMCSA is testing out for future exams. And the catch is, you have no idea which questions count and which ones don't. So you have to answer all 120.
And you need to hit 71% to pass. The good news is you get your score immediately. The less good news is that the official certificate from the DOT, that can take up to 3 weeks to show up in your email.
And this isn't a one-and-done thing. You have to maintain it. Recertification is mandatory no sooner than 9 years and no later than 10 years after you first get certified.
And that renewal is a big deal, I take it.
It's significant. You have to complete another accredited training program, a refresher, and then you have to pass the in-person national exam all over again. Plus, there's periodic training every 5 years just to stay active.
So what happens if you've done the training, but you can't even get online to schedule the exam? I hear that's a common problem.
It is. It's usually a verification backlog issue. Back in 2014, you had this huge flood of providers, something like 17,000 of them, get certified all at once, and the system still feels those ripple effects.
Is there a way around that waiting game?
There is. If you're stuck, the sources recommend 2 things. First, call the FMCSA directly. The number is 612-494-3003. And here's a little pro tip. Press option 2, then 6. You can usually bypass the long greetings.
And the second thing?
Email them. The address is fmctexhset, all one word, @.g.gov. Just ask for a status verification. Knowing those 2 contact points can save you weeks of just waiting.
Okay, so the logistics are messy but manageable if you know the tricks. But all of that is just the prelude to the real challenge, which is the mental shift you have to make to pass.
Absolutely. This is the biggest differentiator between passing and failing. It's the core mindset. As a medical examiner, or ME, you have to answer every single question from the perspective of a regulator.
Not a treating clinician.
Exactly. You are determining a driver's fitness for duty based on risk mitigation for the public, not on the best possible outcome for your individual patient.
That's a huge distinction. And I see that while maybe 60 or 70% of the exam is just the straight NRCME outline, that other 30 to 40% is clinical.
And it's specifically designed to test that boundary. Can you recognize where the regulatory line is drawn?
This is where it gets tricky because we hear from candidates that some questions are based on rules that are, frankly, outdated.
That's a major complaint. You'll see questions about, for example, old diabetes protocols, things that implied insulin use was an automatic disqualifier or required a federal waiver, which just isn't the law anymore.
So why are those questions still on the exam if the law has changed?
It just highlights the lag. There's a huge lag between when a regulation is updated and when the actual test materials get deployed. It's a major trap because it forces you to remember what the rule was, not what it is. It's almost testing your knowledge of the test's flaws more than the current standards.
Let's talk about some of those very specific numbers the test hammers on. What are the key thresholds in, say, sensory areas like vision and hearing?
You have to know the numbers exactly. For vision, peripheral vision must be at least 70 degrees. That specific number is key. For hearing, the standard requires that only one ear needs to pass the whispered voice test at 5 feet.
Oh, just one ear. I would have thought both.
Nope, just one. You don't need bilateral function for that specific test.
And what about functional capacity like cardiac tolerance?
The FMCSA is crystal clear on this. Drivers must be able to achieve a cardiac tolerance of greater than 6 METs, that's metabolic equivalents, on a stress test. If they can't hit that number, they don't meet the minimum safety standard, period.
Okay, let's shift to immediate disqualifiers. This is where an ME has to make a quick, high-stakes call, specifically with medications in mental health.
Right. Some medications are just non-starters. Antabuse, for example. It's an instant disqualifier because it implies a current diagnosis of substance abuse.
And medical marijuana.
That's a big one. It is a federal disqualification, period. It doesn't matter what the state-level prescription laws are. As an ME, you follow the federal rules for commercial drivers, and the FMCSA also explicitly recommends against using Chantix.
What about common controlled substances, say prescription opioids like hydrocodone?
For those, the ME's job is to get specific communication from the doctor who prescribed it. That prescriber has to confirm, in writing, that the driver is safe to operate a CMV on that medication. The ME has to verify that communication exists and is adequate.
And what if a driver comes in and shows clear signs of, say, an emotional or psychiatric issue? Flat effect, no eye contact.
If the ME suspects a condition that could interfere with safe driving, the required action is a referral to a mental health professional. That has to happen before you can even consider certification. And if there's a history of a severe event like a suicide attempt, there's a mandatory waiting period of 1 year, plus you need clearance from their treatment provider.
And there are also red flags that require immediate, almost emergency-level action, right?
Absolutely. The ME has to be alert for things that signal immediate danger. A classic example is a driver with symptoms of obstructive sleep apnea.
Like being extremely tired during the day.
Exactly. They are immediately disqualified until they get tested and, if needed, treated. An even more emergent finding would be palpating a lateral pulsation above the umbilicus with an obvious bruit.
Which could be an abdominal aortic aneurysm.
A possible AAA, yes. That requires an immediate referral for diagnostic imaging, maybe even to the ER. In that moment, the ME shifts from evaluator to lifesaver.
Okay, let's pivot to where the numbers truly are the law. The strict clinical thresholds, especially in cardiovascular health, this is where those mandatory waiting periods really come into play.
This is it. This is the set of rules where clinical judgment really takes a back seat to the regulatory mandate. The biggest one, the overarching rule, is the left ventricular ejection fraction, or LVEF. It must be greater than or equal to 40%.
And that's determined by an echo or a cath.
Echo, cath, or a MGA scan. And if the echo results are, sort of inconclusive, radionuclide imaging is the tiebreaker.
And what are the key disqualifiers that just stop the whole process right there?
Any sign of instability. Angina at rest is a big one, or if a driver's angina pattern has changed in the last 3 months. Also, new ischemic changes on a resting ECG, like a new 1 millimeter ST segment deviation. All of those signal an uncontrolled risk.
So those waiting periods, or WPs, what's the philosophy there?
It's all about ensuring stability. Almost every significant CV procedure has a waiting period to reduce the risk of something happening while that person is driving an 80,000-pound vehicle. And if a driver's had multiple procedures, you have to follow the longest waiting period.
So give us the prime example. A heart attack, an MI, what's the rule?
The minimum waiting period post-MI is 2 months. And this is where the regulation can feel really rigid. Imagine a driver who is 5 weeks post-MI. He's recovered fantastically. LVEF is 65%. He hits 12 VTs on his stress test.
So clinically, he's doing great.
He's doing perfectly, but he's temporarily disqualified, solely because the mandatory 2-month waiting period hasn't passed yet. The regulation prioritizes that standardized waiting time over any individual's clinical success.
That perfectly illustrates that detachment the ME needs to have. What about something more common, like a stent?
A PCI, or stent placement, has a shorter minimum WP, only 1 week. But they have to get an ETT 3 to 6 months after the procedure. And certification, if they get it, is for a maximum of 1 year.
And for CABG, a bypass graft.
The minimum WP for a CABG is 3 months. And a crucial part of the exam for the ME is to verify the sternum has fully healed. You actually test this with resisted arm abduction and flexion.
Oh, interesting.
Yeah. And once they're certified, it's annual recertification, and they need an annual ETT once they're 5 years out from the surgery.
What about structural issues like aortic stenosis?
For that, it all hinges on the aortic valve area, the AVA. If it's mild, so an AVA greater than 1.5 centimeters squared, they can be certified for up to a year, as long as they're asymptomatic. But if it's severe, an AVA less than 1.0 centimeters squared, they need surgery and then have to wait 3 months.
And aortic aneurysms are just a numbers game based on size.
Exactly. It's a non-negotiable size threshold. For an abdominal aortic aneurysm, it's 5.5 centimeters or more in men, or over 5.0 in women. That's DQ. For a thoracic aneurysm, anything over 5 centimeters is disqualifying. Post-surgery for either requires a 3-month WP.
And quickly, what about a DVT, a deep vein thrombosis?
There's no strict waiting period for a DVT, but you're disqualified if you have an active one. To get certified, the cause has to be confirmed, and the treatment, usually anticoagulants, must be stable and monitored.
Let's shift gears completely now to insulin-treated diabetes. The process here is really unique because it forces this three-way conversation between the driver, the ME, and the treating clinician.
That's right. The key document here is the MCSA 5870 form. This has to be completed by the driver's treating clinician, the person who actually prescribes the insulin. The ME can't make a final call without it.
And the monitoring requirements are incredibly detailed.
They are. The driver has to bring in 3 months of electronic blood glucose records. And these can't just be handwritten logs. They have to come from a device that stores the reading, the date, and the time. And it has to be downloadable for the ME to review.
There's a timing trap with that form too, isn't there?
A huge one. The medical examiner has to get that form and start the physical exam no later than 45 calendar days after the treating clinician signs it. If you miss that 45-day window, the form is invalid. You have to start over.
And what if a driver just doesn't have the 3 months of records? Are they automatically out?
Not necessarily. The ME has some discretion here. You can certify them temporarily for up to 3 months. That gives the driver a window to get those records established. We should also mention an HbA1c over 10% is considered out of control.
Right. And finally, the ME has to quantify the risk of hypoglycemia.
Yes, specifically severe hypoglycemia. That's defined as an episode that required help from someone else or resulted in loss of consciousness, a seizure, or a coma. You track that over the last 3 months, and it's reported right on the form. It quantifies that immediate safety risk.
So when you pull it all together, what does this all mean? Our deep dive into the NRCME shows a system that's, well, highly standardized. It's all about quantified safety margins and regulatory stability above everything else.
It is. It forces providers to step away from that personalized care model and just rigorously apply these black and white tables to protect everyone on the road.
And the challenge isn't really the complexity of the medicine, it's accepting that the ME's role is, by design, incredibly rigid.
And while the FMCSA makes you get refresher training every 5 years, a lot of the core standards that the exam tests you on, they rely on expert panel guidance as from 2009 or even earlier.
So